Usually we talk about a medical diagnosis. There's this expectation of mechanical precision. Like you break your arm, the x-ray shows that jagged white line, and the doctor just points and says, there it is, broken.
Right. A very binary outcome. Clean, simple.
Exactly. Clean and simple.
Oh.
But step into the world of oncology and specifically breast cancer. And that simple x-ray machine is really just the tip of a massive diagnostic iceberg. We're looking at a landscape that is incredibly layered. You almost never rely on just a single image.
No, absolutely not. You are dealing with diagnostic muddy waters. A tumor is a living, adapting entity. So finding it, defining it, tracking it, it requires a highly coordinated approach.
Yeah, and for anyone stepping into this field, whether you're prepping for clinical rotations, stepping into an oncology ward, or just fascinated by medical science, understanding this progression is crucial, which is why we're doing this deep dive into modern breast cancer imaging. Our mission today isn't just a high-level summary. This is a comprehensive, scientific, yet totally accessible masterclass for you, the medical learner or young professional.
Because you really need to consider the sheer scale of the disease.
Okay.
We're talking about the second most common cancer in women.
Right, just behind non-melanoma skin cancer.
Yeah, the statistics are just massive. A woman in the U.S. had a 1 in 8 lifetime probability of developing invasive carcinoma. And in 2021 alone, there were an estimated 281,550 new invasive cases.
Wow, over 250,000.
Exactly. But the paradigm has completely shifted recently. We have firmly entered the era of personalized medicine. Breast cancer is no longer treated as a single, uniform disease.
Meaning it's not a monolith. You don't just, apply one standard protocol and hope for the best.
Not at all. Every patient presents a unique genetic profile, which really demands a multidisciplinary team. You've got radiologists, pathologists, oncologists, surgeons, and they all rely on that imaging report. The radiologist's read is essentially the map that guides the entire surgical and chemical assault on the cancer.
Okay, let's unpack this, because if we're building a map, we really have to start at the foundation. Before we get into, futuristic molecular tracking or dynamic contrast, we have to look at radiation-based imaging, the standard mammogram.
Yeah.
Which, honestly, with all our new tech, I'd think basic x-rays would be obsolete by now.
You'd think so, but no. Digital mammography, or DM, remains the absolute mainstay. It is the gold standard for anatomical screening, and nothing else touches it for one very specific, vital task.
Detecting microcalcification.
Exactly.
Which are essentially these tiny flecks of calcium, right? Why are those so important to find?
Think of them as the mineral exhaust left behind by rapidly dividing or dying cancer cells. In about 30 to 50% of non-palpable breast cancers, specifically in early stages like ductal carcinoma in situ, or DCIS, these microcalcifications are literally the only initial sign.
Just those tiny white flecks?
Yeah, and a standard digital mammogram catches those bright white specks beautifully against the softer breast tissue.
That makes perfect sense. And to catch them, radiologists use standard geometric views, right? Like there's the craniocaudal view, the CC, which is a straight top-down look.
Correct, a superior to inferior projection.
Right, and then the mediolateral oblique, or the MLO, which is an angled side view that captures the breast tissue and the pectoral muscle. But, there have to be anatomical blind spots with just those two flat angles.
Oh, absolutely. Human anatomy rarely cooperates perfectly with flat imaging plates. Diagnostic workups frequently require special views to solve, spatial problems.
Like what kind of problems?
Well, if you need to pinpoint the exact depth of a lesion, you'd use a true lateral view. Or if you have suspicion about the far medial tissue right in the valley between the breasts, you'd use a cleavage view.
A cleavage view. And there's also the exaggerated CC, the Cleopatra view, which just sounds incredibly dramatic.
It's a great name, but it's actually just a positioning technique to reach deep into the outer quadrants and the axillary tail, up near the armpit.
Right. And then there are specific material challenges, too, like silicone implants, because silicone is radiopaque, right?
Right.
X-rays cannot penetrate it effectively.
They can't. They just bounce off or get absorbed.
So how do you screen a patient with implants? You can't just compress the breast normally. All you'd see is a giant white blob of silicone completely hiding the actual glandular tissue.
Right, which brings us to the Eklund technique. It's crucial. The technologist physically manipulates the breast, pushing the implant posterior-superiorly.
Pushing it back and up against the chest wall.
Exactly, while simultaneously pulling the anterior breast tissue forward over the imaging plate. It physically displaces the obstacle so you can actually see the biological tissue clearly.
That's brilliant. But even without implants, standard 2D mammography has a massive built-in rentness, which is tissue overlap. If a patient has highly dense fibroglandular tissue, that tissue looks white on an X-ray. And cancer also looks white.
Yes, it's the classic analogy like trying to find a snowball in a blizzard.
Which is why we transitioned to digital breast tomosynthesis, or DBT.
Right, also known as 3D mammography. DBT was engineered specifically to solve the overlap problem. Instead of taking a single stationary snapshot, the X-ray tube physically moves in an arc over the compressed breast. It fires multiple low-dose projections from varying angles.
And then the computer software stitches all those angles together to create these 1 millimeter slices of the breast. So reading a standard 2D mammogram is like trying to read a book by just looking at the cover, whereas tomosynthesis is actually flipping through the pages.
Yeah.
You completely eliminate that confounding effect of overlapping tissue.
It's a game changer. That ability to scroll through the tissue drastically reduces recall rates and false positives. You could immediately see if the density is a true spiculate mass or just normal ligaments and glands that happen to cross pads in a 2D projection.
But here's my question. If DBT is so superior at reducing recall rates and false positives, does it entirely replace the 2D mammogram considering radiation doses? Because if you do a 2D scan and then a 3D scan, aren't you doubling the ionizing radiation exposure?
That's a great question. Doing both physically does double the dose, which we absolutely want to avoid. So the solution is software-based. Modern DBT systems mathematically generate a synthesized 2D image directly from the 3D dataset.
Oh, wow. So you don't even need the physical 2D scan.
Exactly. You get the familiar 2D map for quick reference plus the 3D slices, all for the radiation price of a single scan. There is a slight visual learning curve for the radiologist, of course, but the safety benefit is immense.
And all this, everything found on those scans gets categorized using a universal language, right? The BI RBankit's lexicon.
The breast imaging reporting and data system, yes. It's the absolute standard. It forces the physician to categorize the findings into categories 0 through 6.
0 being we need more imaging, and 6 being known, biopsy-proven malignancy.
Precisely. It dictates the exact likelihood of malignancy and the next clinical steps. And importantly, BI-RADIES also mandates classifying the breast composition into 4 subtypes.
Which are fatty, scattered, heterogeneously dense, and extremely dense.
Right.
Because, as we established, dense breasts are the nemesis of the X-ray. So because radiation-based imaging struggles with heterogeneously or extremely dense breasts, and because it can't always differentiate between a solid mass and a harmless fluid-filled cyst, we have to transition to modalities that rely on sound waves and magnetic fields.
And that starts with ultrasound. It's the immediate problem solver. Unlike the static snapshot of a mammogram, ultrasound is dynamic. It's a real-time tool. You can compress the tissue with the probe and watch how the mass behaves. And the advanced features on modern ultrasound are remarkable.
Yeah, let's talk about those features, because it's not just bouncing a simple echo anymore. You have tools like harmonic imaging. From what I understand, this improves the contrast between fat and the lesions by using higher frequency harmonic sound waves generated within the body itself.
It does. It cleans up the margins beautifully.
Yeah.
You also use compound imaging, where the transducer fires sound beams from multiple different angles at once. This reduces speckle artifact and acoustic shadows, giving you a remarkably smooth, accurate picture of the internal tissue.
But we aren't just looking at structural architecture. Functional ultrasound can actually look at what the tissue is doing.
Yes. Color Doppler is a prime example. We use it to map angiogenesis.
Tumor blood flow.
Right. When a malignant tumor grows, it needs massive amounts of oxygen and nutrients. It secretes chemicals to build its own vascular network. But these tumor vessels are chaotic, leaky, and high velocity. Color Doppler detects that specific erratic blood flow.
And then there's elastography, which tests tissue stiffness. The underlying principle here is that malignant tumors trigger a fibrotic desmoplastic reaction in the surrounding tissue. So malignancies are often hard. Normal breast tissue is soft, like jello. Tumors are like rocks.
Exactly. And elastography visualizes that mechanical property. Sound travels faster through stiff objects. So if the velocities are reading high specifically, if you see velocities greater than 3 meters per second, that is a highly suspicious indicator of a rigid, malignant lesion.
Okay, so sound waves are great, but if we want the absolute pinnacle of sensitivity, we have to talk about MRI. No ionizing radiation, highly sensitive, relying on a magnetic field and an IV contrast agent called gadolinium.
Because we know tumors build those leaky, chaotic blood vessels, we exploit that physiology with the MRI. When you inject gadolinium, it rapidly leaks out of those specific vessels and pools inside the tumor. On the scan, the cancer literally lights up against the normal tissue. It gives you exquisite detail on the lesion's morphology, its shape, its margins, whether there's necrosis in the center.
The MRI also uses a rendering technique called 3D MIP, or maximum intensity projection. It creates this volumetric model to compare bilateral enhancement. So, comparing the left and right breasts. You can precisely map where the tumor is sitting relative to the patient's chest wall.
That geographical map is utterly vital for the surgeon planning a lumpectomy or mastectomy. They need to know exactly how deep to go.
But here I have to play devil's advocate for a second. If MRI is the ultimate tool for sensitivity, if it catches the things that mammography and ultrasound miss, why isn't it the universal frontline screening tool instead of mammography? Why aren't we just giving everyone an MRI?
This raises an important question, and the answer really comes down to logistical constraints. A standard breast MRI takes 30 to 45 minutes. The patient has to lie completely still, face down in a loud claustrophobic tube with an IV line.
It's not exactly a quick drop-in appointment.
Not at all. And it's expensive. Scanner time is incredibly limited across the healthcare system. You simply cannot run millions of screening patients through that bottleneck every year. Patient comfort, time, and cost are massive barriers.
So how is the field adapting? Because leaving that sensitivity on the table seems wrong.
The field is actively developing what we call abbreviated or ultra-fast MRI protocols. By stripping the MRI sequence down to just the absolute most critical, contrast-enhanced phases, you can drop the entire scan time to under 10 minutes. It makes screening much more cost-effective without losing that crucial sensitivity.
That's a huge improvement. Okay, so ultrasound and MRI give us exquisite anatomical and vascular details. But sometimes we need to understand the cellular physiology. We need to see what the tumor is eating.
Yes. You are stepping into molecular imaging, PTCT. Here, we're not looking at physical density or stiffness. We are watching the tumor's metabolism directly.
And the fuel for this is a radioactive tracer called 18F-FDG. Let's break down the cellular mechanism for the learners, because the biology here is so elegant. FDG is basically a radioactive analog of glucose, sugar.
Right. And cancer cells are incredibly metabolically active. They consume glucose at a staggering rate. So when you inject FDG into the bloodstream, the cancer cells eagerly pull it in using GLUT transport proteins.
Like a Trojan horse.
Exactly like a Trojan horse. Once inside, an enzyme called hexakinase phosphorylates the FDG, turning it into a molecule called FDG6P.
But here is the trap. Normal glucose would continue down the glycolysis pathway, get broken down, and be used for energy. But FDG6P structurally cannot proceed to the next step. It's stuck. It can't go forward, and it can't cross the cell membrane to leave. It just becomes trapped and accumulates inside the cancer cells.
The trap is sprung. And because that trapped molecule is emitting positrons, the PET scanner detects the radiation. We can precisely quantify how hungry the tumor is using a measurement called SUV.
Standardized uptake value. Is PT used for diagnosing the initial lump in the breast?
Rarely. Its true power lies in systemic staging, doing a total body scan to assess for distant metastases. If breast cancer cells have migrated, say, to the bone like the sternum, the PET scan will show those bones glowing with radioactive sugar.
Wow.
It is also an exceptional tool for evaluating response to therapy. Clinically, it's great for determining if a residual mass post-treatment is viable tumor tissue or just fibrotic scarring. If it doesn't take up the FDG, it's just metabolically dead scar tissue.
Here's where it gets really interesting. Not all breast cancers absorb this tracer equally. Different histologic subtypes and receptor statuses actually influence how much tracer the tumor absorbs. An aggressive triple-negative or HER2 positive tumor is going to gorge on the FDG, lighting up intensely. But a slower-growing hormone receptor positive tumor might absorb very little. It makes this a truly personalized imaging method.
It really does. You are visualizing the distinct personality of that specific tumor. But seeing the tumor, no matter how detailed the image, is still just looking at shadows. Once we have identified and mapped the physiological activity of a suspicious lesion, we must obtain a tissue sample to confirm the pathology.
Right. You have to take a biopsy. So how do we choose the right tool to guide the needle? Because there is a strict hierarchy here, right?
Yes, ultrasound is universally the first choice.
Because you can actually watch it happen in real time.
Real-time visualization is a massive advantage. Plus, it's comfortable for the patient, low cost, and there's no ionizing radiation.
But what if the lesion is completely invisible on ultrasound? Like those tiny microcalcifications that only showed up on the mammogram.
Then you step up to tomosynthesis or stereotactic guidance. The patient's breast is compressed, and the machine calculates the exact coordinates to physically guide the needle.
Leaving MRI-guided biopsy as the absolute last resort.
Yes. Due to the high cost, the length of the procedure, and the contrast limitations we discussed earlier. It's only used if the lesion is exclusively visible on MRI.
And no matter which method you use, post-biopsy clip placement is mandatory to mark the site, right?
Absolutely. You deploy a tiny metallic clip to leave a permanent flag marking the exact coordinates of where that tumor was.
Speaking of surgical maps, there are preoperative localization techniques used right before surgery, like SNOL and roll.
Yes. Instead of just a metal clip, a radiotracer is injected precisely near the lesion and the sentinel lymph node. In the OR, the surgeon uses a gamma probe to detect the radiation, guiding the scalpel directly to the diseased tissues.
Now let's talk about neoadjuvant systemic therapy, or NST. This is treating the patient systemically before surgery to shrink the tumor. We rely heavily on contrast-enhanced mammography, or CEM, and MRI to monitor if the tumor is shrinking. But I have a vital clinical question here.
Go ahead.
If the breast MRI shows the primary tumor is shrinking rapidly from the neoadjuvant chemotherapy, can we safely assume the axillary lymph nodes are completely clear too?
Definitely not. That is a dangerous assumption. The response to NST in the breast and the axilla is not always identical. You might achieve a complete response in the breast while the lymph nodes stubbornly hold on to viable disease. They must be evaluated and monitored separately.
Never assume. Okay, so our imaging toolkit must also adapt once a breast has been fundamentally altered by surgery or biologically altered by pregnancy.
The postoperative breast is incredibly complex. Your primary job is distinguishing benign surgical scarring from a malignant local recurrence. Scars should sequentially decrease in size on follow-up mammograms over the years.
So if you're comparing films and a scar grows, becomes denser, or mass-like,
Recurrence must be highly suspected, prompting an immediate biopsy. You also have to navigate reconstruction artifacts from implants, autologous fat grafts, and muscle flaps like the tram flap.
and those procedures can cause localized trauma leading to fat necrosis or steat necrosis.
Yes, which can visually mimic recurrence. It takes an expert eye to differentiate the body's confused repair job from a returning tumor.
And biological changes completely shift the landmarks too, particularly with pregnancy-associated breast carcinoma, or PBC.
PBC is defined strictly as breast cancer occurring during pregnancy or within 1 year postpartum. It affects about 1 in 3,000 to 10,000 pregnancies.
That's relatively rare, but from what I understand, these tumors are highly aggressive, right? Often triple negative or HER2 positive.
Very aggressive.
Yeah.
And you obviously want to avoid ionizing radiation in a pregnant patient, making ultrasound highly effective and really the primary tool here.
But the biological state of the breast fights you. If the patient is lactating, the physiological changes, like secretory hyperplasia, make imaging incredibly complex.
The milk ducts become engorged, density skyrockets, requiring careful differentiation from true malignant masses.
Evaluating a postoperative or lactating breast is like trying to read a map that has been crumpled up, drawn over, and refolded. The normal landmarks have shifted.
That's a perfect analogy.
So, synthesizing all of this, modern breast cancer imaging is an interconnected web of modalities. You cannot practice effectively in a silo. Understanding anatomy through mammography, physiology through PT, and dynamic properties through ultrasound and MRI is vital for personalized patient care.
Exactly. And the field is still evolving. Think about this. The future of neoadjuvant therapy monitoring lies in artificial intelligence. The massive data sets extracted from a single breast MRI are currently being trained with machine learning to objectively predict tumor responses.
Wow. So predicting how a tumor responds before we can even see the physical changes.
Exactly. It raises a provocative thought. Will the radiologist of the future be a data scientist as much as a physician? The interpretation of disease is becoming highly mathematical.
So what does this all mean for you? To reinforce the material for you, the medical student or young professional listening, let's do a rapid-fire clinical exercise.
Let's do it.
Imagine you have a patient who presents with a palpable mass. The initial mammogram shows a developing asymmetry, but the tissue is highly dense. You need to perform a percutaneous core needle biopsy. Based on our deep dive today, what imaging modality should be your first choice to guide the needle, and what are 3 reasons why? Take a second.
Think back to the hierarchy we discussed.
Okay, if you said ultrasound, you are correct. As we explained, it provides real-time visualization, it avoids ionizing radiation, and it is significantly more comfortable and cost-effective than MRI or stereotactic guidance.
It really is the optimal first step.
Which is exactly what mastering this field is all about. Thank you for joining us on this deep dive into modern breast cancer imaging. The next time you look at an imaging report, remember, it's a multi-layered map. Keep exploring those muddy waters. Catch you next time.